Hello everyone, my name is Muhammad Arnous. I am PGY2 internal medicine resident at Mercy Hospital Fort Smith, which is affiliated with Arkansas College of Health Education or Arkansas College of Osteopathic Medicine. So I'm presenting today a rare case of heparin-induced thrombocytopenia and thrombosis type 2 in a patient with essential thrombocythemia that was confirmed with JAK2 positive BCR-ABL1 negative. So first, what is heparin-induced thrombocytopenia and thrombosis type 2? It's actually a rare and life-threatening condition. It can occur in patients exposed to heparin, and most interestingly, regardless of the type, dosage, or route of administration, whether it's subcutaneous, IV, and this condition resulting from autoantibodies against platelet factor 4. And that leads to venous and arterial thrombosis. Mortality rate is very high. It's about 20% if we didn't do any identification or treatment. However, if we did appropriate treatment for it, it ceases down to 2%. Sorry, to 2% only. And essential thrombocythemia, it's a condition that is related to BCR-ABL1 negative myeloproliferative neoplasm and is often asymptomatic, however, might lead to thrombotic complications, and that's what was going on in our patient here. So, treatment involves risk-based strategies like aspirin, hydroxyurea, pegylated interferon, and following the severity staging of essential thrombocythemia according to EPSID thrombosis manuscript or guidelines. So our case here is a 62-year-old lady. She has confirmed essential thrombocythemia, was getting treatment outpatient with apixaban, which is well known in the market as Eliquis, and the pegylated interferon. The patient presented 3 weeks post a stent called the Viban stent. It's a coated stent, and she presented with left lower extremity pain, and that was like distal to the stent itself. So it was a little bit odd how she is coming after a stent, and the suspicion was like the stent has moved or there was something related to it by itself. And she had a pain, swelling, and scarring prompt initiation. We did started her on heparin drip in the ER, leading to admission as well. We admitted her for angiography, and while we are getting basic lab work, including CBC, CMB, we found that her platelet count was 508. However, we were also looking at prior numbers for her platelets, and they were running in millions. Last one before coming to the hospital, 3 weeks before actually, 3 weeks before presenting, and at the time of having this stent, Viban stent, it was running about 1,297,000. So that's a drop more than 50%. So if we were just looking at the number of the platelet count, we would have been fooled by that, because like it's a very high number. It's even higher than the normal population. However, in this certain population, we only need to look at the percentage. So looking at it gave us the idea that she lost more than 50% of her platelets, and she has received heparin about 3 weeks ago. So all this prompted the idea that she might has developed HITT type 2. So we planned on starting her on argatroban. We stopped heparin instantly and started her on argatroban as a trial to bridge her into warfarin outpatient. So we did as well angiogram with thrombectomy, and TPA alteplase was performed on day 2. And by day 3, the patient was stabilized on argatroban, pain-free. Her symptoms has been improving drastically, and her INR was between 2 to 3, which is a goal for us to continue on warfarin or discharge her on warfarin. And we allowed to transition to oral warfarin, and started her also on clopidogrel as well as aspirin. So our discussion here briefly is about that diagnosing HIT type 2 in hypercoagulated state like essential thrombocythemia is very challenging. And the second important point, as I mentioned, is that platelet percentage drop is more important than the count in HIT type 2. And the third point is that heparin in essential thrombocythemia should be given with caution. We found actually some population, especially in Europe, that has the same thing, especially in patients with essential thrombocythemia.